Alright? So what is ultrasound? It's basically just high frequency sound waves. It's produced by the electricity passing through piezoelectric material. So we utilize this ultrasound and being transformed into images so that we can view structures like veins, arteries, nerves, muscles. Yeah. So as the sound passes through tissue, it can be either absorbed, reflected, or just pass through. And this depends on the echo density of the tissue. So the appearance of the substance depends on the ability of the substance itself to conduct sound. Okay. Whether a substance appears dark or bright on the ultrasound depends on the amount of wave they reflect. Okay. So this is basically a picture to show that how the image is produced. So the ultrasound will produce the wave and send it to the organ. The organ will either absorb or reflect, and then the image will be produced on the screen. Yeah, this is another picture to illustrate what I meant just now. So if a structure has high water content, like blood, cerebrospinal fluid, then they conduct the sound very well. So the sound will just pass through. So once the sound passes through, very little get reflect back. So what happened? The image is very black, dark. So we call it hypoechoic. So, but if the water content is very low, like if it's air, if there's bone, then they reflect all the sound. So it appears very bright on the screen. So or we term hyperechoic. So we utilize these features to understand certain structure, how they form, how they look on ultrasound. Classical example is the vessels which carry blood. They're actually anechoic, means they conduct sound. The sound just passes through and it appears black on the screen. And we utilize other features like compressibility or pulsatile to differentiate whether the vessel is an artery or a vein. Then fat is hypoechoic. Muscles are mixed, heterogeneous because they got mixed connective tissues. Fascia is hyperechoic. Lungs, we've got the hyperechoic line with like comet tail. Yeah. Then nerve is either mixed hyper or hypoechoic. So we utilize this basic knowledge to understand how certain structure looks like on ultrasound. Then the other thing you need to know when you use ultrasound is certain features of the wave, the ultrasound wave, like is the one of the term being resolution. Resolution means how clear the image is. It depends on the frequency. So the higher the frequency, the better the resolution. So usually we choose, we want to do blocks or we want to do vascular access. The structure is very superficial. Then you choose high frequency probe to get a very clear image. But then ultrasound wave get attenuated, means the wave will die off as it goes deeper down like example, if you're scanning an abdomen or lung, as the ultrasound penetrates deep into the structure, the wave die off. So if you use a high frequency, the higher the frequency, the more the attenuation. Means if you use, so in conclusion, if you use high frequency probe, you get very poor penetration. So it means when you want to scan deeper structure, you cannot use a high frequency probe. You cannot see because the wave die off, so the image will become very not clear. So if you are scanning abdominal structures, spine, you have to use a lower frequency probe to get a better penetration. But the resolution is not that nice when you use a low frequency probe. So this is the thing you sacrifice image for penetration. Alright. So reflectivity. because when we scan images, the sharpest image is obtained when your ultrasound probe is at 90 degrees with your desired structure. So it means if you tilt your probe a bit, then the ultrasound is not 90 degrees, then the image is lost. So that's why when we scan, we need to sometimes make sure that our wave is at about 90 degrees to the intended structure. So that's why we have this technique called tilting. Okay. Then refraction. Not all the waves are reflected impact into the probe. Some are just refraction means it goes sideways. So this will affect the image. So it will not be the sharp image. It will become a bit blurry on the screen. Okay, this is the illustration to when your beam comes in. Not all of it get reflects back. Some of it get absorbed. Some of it goes reflected in a certain angle we call refraction. These will all affect the image. So probe selection, what kind of probe you want to select? Like I said, if you want to, there are basically a few types of probe, but basically when we do nerve blocks or vascular access, usually we'll use the linear probe. And sometimes there's another option of a smaller linear probe when you have a smaller anatomy, like children. Yeah. But basically, if you use a smaller linear probe, then you sacrifice the view, the field. Your field gets very narrow. Sometimes you want to see a larger field, so you usually will select this one. The curvy linear probe is a low frequency probe. So low frequency means you don't get a very clear image, but the penetration is better. So you use it for abdominal structures, spine. This one is for most of the nerve blocks, and the linear probe is used for most of the nerve block and vascular access. Okay, right. So modes. So when you use ultrasound, also you need to understand there are certain modes that you can utilize to either improve your image or to differentiate whether that is a vessel or there's an artery or vein in the way. So the B mode is just the usual mode that we always use, the basic two-dimensional image that is produced on the ultrasound. Doppler, yeah, Doppler basically is used to detect you use color Doppler to detect artery or vein or small vessels. M mode, sometimes when we use a single beam, we can in a floating structure, we can see this is used for more of echo or for lung ultrasound. Then ultrasound instruments, yeah. One of it is a time gain compensation. When just now I mentioned that the frequency and penetration. So sometimes in deeper structure, you find that the image is blurry. You want to you can increase the gain to make it brighter because it's too dark. Because the image cannot be seen, so you increase the gain. But by increasing the gain, sometimes you can see the structure better, but there will be more noise. Means there will be the other areas surrounding the structure. The gain will increase. It will become brighter also. That's the downside of gain. But you can improve your image a bit. But the surrounding structure also become brighter sometimes, and then it might affect your view of the image also. So, yeah. So where do we adjust the gain? A lot of machines are nowadays in the ultrasound. They have auto gain, so the ultrasound itself will adjust the gain for you. But if not, there will be a slider knob or a rotatory knob somewhere with the right gain there, so you can adjust the gain, and you can adjust the slider knob, and you can adjust one by one one part of the image. I'll show you in a while where to adjust the gain. So this is an example of how we utilize gain. If your image is too dark, you can increase the gain. You want to see maybe probably this structure here. But then sometimes you adjust too much, then it becomes the image in the center, the gain too much. So then you adjust back, then you get the optimum gain that you want. You can see, you review the structure, but not too bright. Dynamic range. Dynamic range simply means the number of grayscale. If you cannot understand what is dynamic range, it just means that you increase the grayscale in the image. Sometimes the image is too black and white. Sometimes you want to see fascia, muscle, then you need a bit of grayscale. Yeah. So this is without dynamic range. This is with more, the next one is with dynamic range. Yeah. Okay. Focusing. So sometimes in the image you want to see just one particular area. Then you can concentrate your beam, your ultrasound beam in that area. Yeah. So you want to focus your ultrasound beam in the center of the image or below the image or above the image. So you can adjust the focusing. Usually the focusing is represented by this line, this image here. All the ultrasound will have. So you can adjust the focusing. You can adjust this button here. There is a button for you to adjust to move this focus up or down. So if you want to see the image on the top more better, so you push your focus up, or you can adjust your focus down. Right? So how do we optimize our ultrasound image? So you need to have some knowledge of anatomy, because you need to find what you want. You have to have a structure in mind. So, like example, when we want to find nerve, you can usually look at you need to know what the structure surrounding the nerve. Like example, there might be an artery beside the nerve. There might be a vein, or might be a specific muscle that you are looking for. Okay. Nerve can be, because nerve is a bit difficult. At the proximal, like example, brachial plexus or nerves in the upper limb, if you look at the brachial plexus, it looks like this, hypoechoic. If you go peripheral, the more peripheral you go, the nerve becomes more mixed, hyper and hypoechoic. Okay. So this slide, I just want to illustrate that nowadays certain ultrasound, they have this modality called the compound imaging. Compound imaging is just that the ultrasound will filter out noisy images. Noisy images means the image that is too bright or too dark. Like example, this one. This image, there is no compound imaging. The image is very rough, sandy-like. So if nowadays some ultrasound, they have this modality called compound imaging, they will automatically make the image nice, sharper, increase the resolution. Okay. Then how do you optimize your ultrasound? First of all, you must select your probe, optimal probe selection. Yeah. If you are doing like example, if you want to do superficial structures, then you select a higher frequency. Then if you want to go for deeper nerves like sciatic nerves, or you want to scan the spine, then you have to lower your frequency. Then there are 5 functional components you need to use. You need to understand how to use when you try to optimize your image. First is get the adequate depth. The adequate depth of your view. If your structure is very superficial, you don't select a very high depth. So, then the frequency is frequency is by your probe. If you select the appropriate probe, you'll get the appropriate frequency. And you can use gain to increase your frequency. If you have already selected the correct probe, then your image is still very dark, you cannot see anything, or you can then you adjust your gain, increase your frequency. The gain you can either, some machine is automatic gain, some you have a rotatory knob to increase the gain of the whole image, then or you can use the slider knob to increase one by one, one layer by one layer. Then focusing, you want to focus on which image, then you can also adjust. Then maybe you want to identify a vessel, then you can use Doppler. Alright. Okay, appropriate depth. This is illustration depth. Sometimes you want to see this structure, you don't have to see the rest, so you just adjust your gain. Depth, sorry, adjust your depth. Okay. Then appropriate gain. So this image is too dark. So you want this one probably too bright. This one probably just nice. So how do you adjust your gain? Oh, sorry, focusing. You want structure. Do you want to the nerve here? Okay. So you can focus this over here. If it's too, you focus here, then you will the ultrasound beam will concentrate here. Then this is not. Then you'll miss your target. You cannot see your target. Alright. So gain, you can adjust the whole gain, or you can use your slider knob to adjust one by one. This one represents the top part, and then the middle part, then the lower part. So there are two ways to adjust the gain, or three ways actually. Some machine automatically adjust for you. Some you use a rotatory knob to adjust the whole image. Then you can use a slider knob to adjust one layer. Artifacts. Sometimes in ultrasound we have a lot of artifacts. One of it being shadowing artifact. So like if you, especially when the ultrasound beam pass through a bony structure like a spine or a rib, then below it there's nothing. Okay, then this is called the shadow artifact. Acoustic enhancement. Sometimes you have this overly intense echogenicity behind the object. For example, this is a femoral nerve, but underneath here there's a acoustic enhancement below the femoral artery. Yeah. So reverberation. Sometimes you see multiple images. Usually the needle. You see a lot of small one needle, and then you can see multiple smaller needles below it. This is called reverberation. Mirror imaging also, sometimes you can see one on top and one on down there. Velocity error, you can see sometimes the speed of ultrasound is different, and then you can see sometimes your needle gets bent. This is because of velocity error. Air artifact, so sometimes when you didn't put enough gel, or when you cover your probe, there's a air bubble inside there, then you will see something like this, a very dark area. Yeah. Okay. Okay. How do we optimize our sonor anatomy? How do we? Yeah. So first of all, choose the right probe. Then you need to have some form of anatomical knowledge, and then you need to apply a variety of pressure to either you tilt, slide, rotate. So what we use is the mnemonic PART, P-A-R-T. You use pressure, alignment, rotation, or tilting. So sometimes this heel approach also, you make the heel approach is to make the transducer face more parallel to the needle. So pressing on the edge of the transducer to the opposite side of the needle direction, insertion, sorry. So it means you actually make your probe closer to your needle. This is called healing. Or you can rotate, or you can tilt, or then if some of us will do hydrodissection to see where your needle is. Then you just inject some saline, and then you can see where your needle tip is. Right? So healing, this is a picture showing healing. You put your transducer lower to closer to your needle. Make it more superficial. make it more flat. Lateral slide, you want to slide your transducer nearer to your needle. Okay. Anisotropy means that actually anisotropy simply means that you want to scan, you want to make your ultrasound beam at 90 degrees perpendicular to your structure. Some structure like blood vessels or nerve, if you don't shine your probe perpendicular or at 90 degrees to it, it will become blurry. So you find that if you tilt a bit, then the beam shines 90 degrees to the structure, it becomes very clear. This is an example of anisotropy. If the patient is lying flat, this is a popliteal sciatic nerve. But you find that the nerve looks like so blurry, but if you just tilt it a bit, and the ultrasound beam will shine 90 degrees to the nerve, then it becomes clearer. So performing the block, all right. Before we perform a block, we always try to scan first to identify the appropriate depth, the appropriate image, gain. Then after setting everything, then we scrub in, and then we wrap the probe. Then we perform the block. Okay, you can the tip is do not advance the needle if the tip cannot be localized. So you have to try to localize your tip of the needle by using the tips given just now. Either you heel, you rotate, or sometimes very deep structure, very difficult, you can try to hydrodissect. When pushing through a fascia towards a nerve, approach in a tangent means a certain angle, so you don't poke directly into the nerve. When we poke underneath the nerve. Yeah. All right. Okay. So when you poke through the fascia, there will always, because the needle is blunt, there will always be a pop. Then after a pop, you realign your needle with your probe again to find the tip again. Okay. All right. So always, when you are doing blocks, you inject the local anesthetic in small aliquots. Inject slowly, because sometimes if you are too near to the nerve, patient will have pain. Most of the time, if you are very near to a nerve, they will have paraesthesia. But sometimes with injection, there will be pain. And then you aspirate in between injections to make sure that you are not in the vessel. Always try to, if you are for nerve, you try to create a halo of, means you surround the nerve with the local anesthetic. Yeah, right. If you are doing fascia block, you try to fill up the fascia with LA. Right. Then ergonomics also very important. Example, this one. You try to make yourself comfortable. Always put your ultrasound in front of you and adjust the height so that you don't have to bend. Because sometimes in a difficult block, you can do it for like half an hour. Then if you tilt or turn your neck, you might get a lot of the backache or neck pain afterwards. So stabilize your probe. If you hold at the tip, sometimes you find that it's very hard to control. Then when you are doing the block, the image keep on running away. So what we usually do is we will hold the probe at more distal, and then we rest our wrists on the patient, so that this thing will not, there won't be any fine movement. Yeah. Okay. So long axis versus short axis. So it's just meaning that axis is the view of the structure in relation to the ultrasound beam. So long axis means that the image, you scan the image along the length of the nerve or the vessel. Usually for nerve block, we do short axis. For blood vessel, you want to cannulate like the internal jugular vein, you can do long axis, short axis. But for nerve, usually it's short axis view. Alright? In plane, out of plane. Usually for nerve block, we do in plane, because in plane you can see the whole length of the needle. For blood vessel, for venous cannulation, sometimes we do out of plane. Out of plane can be a bit difficult because you are just trying to find a dot. The tip of the needle is shown as a dot on the ultrasound. Yeah, this is in plane technique. out of plane, you are just looking for this dot, and you advance your probe as the dot advance. So it can be difficult because this can be the tip, this can be also the shaft. Yeah, so this is a bit tricky. All right. Okay, that's all. Thank you. All right.
Thank you. Thank you, Dr. Ng Sze Teck. So, is there any question from the floor?
Have the curved ear probe for the not can we still use the linear probe?
You mean for the sciatic or for you will have a problem when you want to scan very deep structures. You don't have the you don't have the curvy linear abdominal probe. What we use, we call it the abdominal probe. You can still perform the popliteal sciatic, and up to a certain extent, probably you can actually trace the sciatic nerve, because sciatic nerve is actually very the anatomical wise, at behind the thigh, the sciatic nerve will ascend behind your hamstring muscle, and you know at the mid thigh the hamstring muscle is very thick. So at mid thigh the sciatic nerve is behind hamstring muscle, so it is very deep underneath. So usually you cannot see, it becomes very deep, like 5 cm deep. Unless your patient very thin, then it's okay. And then as it
Anterior approach, what can use the linear
unless the patient is very thin, because the anterior approach also, the depth, you're looking at depth of more than 5 cm, so it can be very challenging. A sciatic nerve anywhere mid-thigh, subgluteal, transgluteal, anterior, it's very challenging if you don't have the appropriate probe. Unless the patient is very thin, then it's okay. Because for linear probe, actually the advantage is the image is very clear, the resolution is very high, but the penetration is very poor. So definitely you cannot do for big patients or for certain cases of lung and spine. You will find it very difficult because the intended structure is deep, above 5 cm, 8 cm, 10 cm. The image becomes very blurred. You can increase the gain, but you find that the whole picture becomes very bright, and you cannot differentiate anything. Yeah, that's the usual problem. Yes. But for superficial structure, like you can do upper limb, brachial plexus, interscaling, all usually, like I said, for most nerve blocks, you will use the linear probe. Even for popliteal sciatic nerve at the popliteal fossa, or slightly you can go 10 cm, 15 cm above, you still can use the linear probe. Yes.